Well, good afternoon or good morning, depending upon your time zone. Welcome to another one of the webinars hosted by the Drug-Drug Interaction Clinical Decision Support Research Group. My name is Dan Malone, and I am a professor at the University of Utah and have been working on the issue of drug-drug interaction clinical decision support for the better part of 20 years. And today we're going to take a look at existing tools within the Cerner platform to improve and monitor drug-drug interactions. So I'm really excited about today's webinar. So we appreciate you attending. So for those of you that have joined us live, you can put a question in the question and answer chat, and we'll try to get to those. Toward the end of the webinar, we'll open it up for people to be able to verbalize those comments or questions. Just for my own benefit, if you've attended one of our webinars in the past, if you don't mind just raising your hand and give us a sense of how many people are coming back and perhaps, I guess, a sense also of how many people are new. It's their first time attending one of our webinars. So. Okay, quite a few people have attended before, so thank you for coming back to our webinars. For those of you that haven't attended one of our webinars before, we do hold these periodically, and we record them and then put them up on our website, DDICDS.org. Well, let me tell you a little bit about our team. I'm going to advance the slide. So again, my name is Dan Malone. I'm at the University of Utah. I have colleagues from the University of Arizona, the University of Pittsburgh, University of Washington, also Mercer University, and health systems being a part of the team. And today, I'm glad to be joined by two individuals who tell us about their experience working with the Cerner EHR software system. Before we get to that, I want to tell you a little bit more about our group. We have a website called DDICDS.org, and that's where we place our webinars. And so here's just a screenshot of our website. And the goal of the website is just to allow us to communicate to you individuals who are in the trenches working with electronic health record systems that provide drug interaction alerts. And to give you a sense of what we're trying to do is, as a group, we're trying to contextualize drug interactional algorithms to reduce alert fatigue. That's our main focus. And then also disseminate and provide algorithms that might be useful in healthcare organizations. We're really interested in your experiences. So if you have implemented one or more algorithms that we put up on our website, we'd love to hear about it. So feel free to email us, and actually at the end of the presentation, I'll give you my email as well. I guess it's the next slide I will. But we're interested in challenges or issues that you have, so feel free to reach out to us. We'd love to talk to you. Yeah, my email is here at the bottom of this particular slide. So, and we're really interested in how effective alerting is, with respect to, I guess, how many of these alerts occur and how often they're overridden. We really can't get to true measures of effect, meaning preventing actual harm, but we're trying to figure out if we can tailor some of our alerts such that we provide the right information to the right person at the right time, fulfilling some of the 5 rights of meaningful clinical decision support. So for today, what I want to do is have two individuals, Andrew Romero and Dave Glover, talk about their experiences. So Andrew is a pharmacist with over 15 years in the industry, in healthcare practice. He was actually one of my students at one point in time. I don't know if he wants to admit that, but I'll claim him because he's really talented. He has lots of experience in dealing with pharmacoinformatic issues, including maintaining dispensing systems, smart infusion pumps, and also just taking that information and using it in Excel, making use out of that data. Our other speaker is Dave Glover. He's a pharmacist at the Northern Lights Healthcare Organization in Maine. Dave has been working in the CPOE involvement since 2007, and was part of a team that received the HMS Davies Award in 2008. He's continued to implement a variety of solutions in the Cerner environment, including MCDs, dose range checking, barcoding, administration, MedRec, and various other things. So what I'd like to do is turn it over to Andrew, and then we'll hear from Dave, and then we'll bring it back to me at the end. So I'm going to stop share. So Andrew, feel free to open up your screen and take it over.
Okay, good morning. It's a pleasure to be speaking with everyone today. As Dan Malone mentioned, so I've kind of worked on different EHR systems, and doing alert management has been a large part of my job since I've gotten into the informatics positions it's been about since 2006. I've worked on doing alert reduction for Alaris, smart pumps, drug-drug interaction alerts, duplicate therapy alerts. So alerts are always there, and we always kind of want to decrease the number of alerts down to a manageable level. So this is kind of continuing in that same theme. So today we're going to be focusing on drug-drug interaction alerts within Cerner. We've organized this webinar into two parts. So I'll be discussing how to use the Cerner Lights-On network to identify your most frequent drug-drug interaction alerts and which ones are being overridden most frequently. And then David Glover is going to be going into some of the technical aspects of how you can affect those interactions and decrease the number of alerts. So, okay, so the Cerner Lights-On network is a web-based analytics tool. It's really designed to look at various metrics across different organizations or across different facilities within an organization. So not only does it show drug-drug interaction alerts, it also shows drug allergy alerts. It also shows other metrics such as BCMA or bedside barcoding numbers. So it's really meant to be kind of an overall dashboard of how Cerner is operating for your site. The site does require registration. That registration needs to be approved by your organization. So once you submit a request for a Cerner Lights-On network, Cerner will then contact the point person at your organization to make sure that it's appropriate for you to have access to the site. So I have a link to the Cerner Lights-On network down here. Once you go to that site, you're going to be brought to the Lights-On network. You can click the Access dashboard. That's going to bring you to the login page. One really nice feature that the Cerner Lights-On network just implemented recently was the ability to log in with your Cerner Millennium network ID. So you don't have to remember a different Cerner Lights-On network and a different Cerner login information. So it's going to be the same as your regular Cerner login. So once you log into that Cerner Lights-On network, you're going to be brought to an operational scoreboard or a dashboard. This is really a high-level overview of various metrics. So it's meant to be a customizable dashboard. So if you want to always view drug-drug interaction alerts and BCMA rates, you can customize that scoreboard to display different metrics that you are interested in. Again, today we're going to be interested in the drug-drug interaction alerts. So in order to view that data, you can click on the workforce experience and decision alerts. So this is what that operational scoreboard looks like. And again, it's customizable, so you can show whatever you want on this screen. The workforce experience is in the lower left-hand corner. Once you click on that workforce experience, it's going to bring up a pop-up menu where you can select decision alerts. So within the decision alerts page, you're then able to select a month or a particular day or date range that you want to view. The Cerner Lights-On network will then load data on all the alerts fired. So this includes drug-drug interactions, but also includes discern alerts, drug allergy alerts, duplicate therapy alerts. So basically any alert that's fired within the Cerner environment. So the dashboard is set up to show all alerts that frequently fire, and then we can go and we can filter it to say we just want to look at drug interactions for the purposes of this webinar. So this is what the decision alerts dashboard looks like. So at the time, we're showing data from April 2021. So we can see that the total alerts fired during that month were 9.4 million. We can see that the override rate for all alerts is 86.1. Down here is a key for what type of alerts you're seeing. So most of our alerts are actually discern alerts. The next highest category is duplicate therapy, and then we have drug-drug interactions is the orange color. However, when we look at the override rates, we can see that duplicate therapy has the most override rates, and then drug-drug interactions actually have the next most override rates. As you hover over each one of these sections on the web page, you can see additional information. So you will see the actual amount of overrides and then the actual override rate. So for duplicate therapy, we have an override rate of 93.6%. When we hover over the drug-drug interactions, we had 200,000 drug-drug interactions during April, and that had an override rate of 93.8%. So on the same page, if you scroll down, you can see the scatter plot here where you can filter it to only show drug-drug interactions. So it's going to default to show all alert types. That scatter plot is useful because it's going to show you the drug-drug interaction alerts and the override rates for individual interactions. So it's important when you start looking at alert management, you want to really focus your energy where you're going to see the biggest impact, sort of the biggest bang for your buck, because it's often going to take you the same amount of time to solve an alert that comes up 4 times a month as opposed to something that shows up, 400 times a month or 4,000 times a month. So you really want to make sure you're focusing on the alerts that are going to have the biggest impact. So you can hover over each one of the plots to view details, and you really want to focus your attention on the alerts in the upper right quadrant. That's going to be the highest number of alerts and the highest number of overrides. So this is that same web page that has now been filtered to only show the drug-drug interaction alerts. Along the y-axis here, as you go up, the override rate gets higher. On the x-axis, as you go further right, you have more alerts firing. So these ones that are over here in the upper right-hand quadrant are really going to be the biggest bang for your buck. They're firing frequently and have very high override rates. As you hover over each one of these plots, it's going to give you the information for that interaction. So the alert that fired the most, the drug-drug interaction alert that fired the most is dexamethasone, measles, mumps, rubella virus vaccine. That is a drug-drug interaction alert. It's currently classified as a major contraindicated alert. It fired 4,611 times during April, and it had an override rate of 95.1%. So the next one that fired most frequently at our site is acetaminophen, oxycodone, and gabapentin. So it is classified as a major interaction. It has an override rate of 94.8%. So next, haloperidol ondansetron is a major contraindicated alert, has an override rate of 89.3%. So one way that I like to think of alerts is, and particularly when you're looking at override rates, is you can say that it's almost like voting. So we displayed this particular alert 3,149 times. 89% of the time, people voted that alert was not useful, and they essentially continued on with the interaction. So we either have one of two things going on. 89% of the people are making the wrong decision here, and it should really be causing a change of practice, or there's some kind of nuance to this particular interaction that should be filtered, or there are additional factors such as age, renal creatinine clearance that are going to play more into that particular interaction. So then our next interaction is amiodarone oxycodone, which still has an override rate of 96.6%. So those are all examples of interactions that are firing frequently and that have a very high override rate. So they would be good, those would be good ones to focus your attention on. So you can also get some more information on each one of those drug interactions. If you scroll back up to the top of that page, there is an alerts fired tab. So once you click on that tab, it does take some time to load all the alerts. You can scroll down and then filter it again to just drug-drug interaction alerts. So this is that same web page. When we scroll up to the very top of it, before we were on the overview tab, we're going to click on the alerts fired tab. That gives you this type of a chart where we can change the alert type from all to just drug-drug interactions. So this essentially gives you the same information, but it gives you it to you in a better layout where if you needed to display this for a spreadsheet, you could do that. It will show you the number of alerts fired. As you hover over each one of the bars, it's going to then give you the same information for how many times that particular interaction fired and then what the override rate was for that interaction. So here's our amiodarone oxycodone interaction again. It's showing the same override rate of 96.6%. If you are wondering how many times a particular drug-drug interaction is firing at your site, you can also use the Cerner Lights On network for that. You can click the drop-down arrow under select alert name, uncheck all, type in a drug of interest, and then select the drug interaction of choice. So on that same graph, I clicked on the drop-down menu, I typed in amiodarone. I'm now seeing all the amiodarone drug-drug interactions. Let's say I'm interested in amiodarone oxycodone to see how many times that particular interaction is firing. I can select that, hit apply, and then I'm going to get the information on just the amiodarone oxycodone interaction. So again, it's showing that it was overridden 96.6% of the time. So you can also get some additional alert details by clicking on the drug-drug interaction pair and selecting a view alert details from a pop-up menu. So that's going to give you information on the individual users that are actually receiving the alert. So here we'll stick with amiodarone oxycodone. Once I click on that amiodarone oxycodone, a pop-up menu will come up. I'm going to select view alert details. Once I do that, it's going to give me information on just that particular interaction. So here we're looking at the number of alerts that fired for amiodarone oxycodone. So on the left-hand axis, we're seeing the number of alerts fired. So we can see that for each month, we're probably averaging around 2,800 alerts per month. And then on the right axis, we're seeing the override rate. So our override rate is remaining consistent at above 95% across the last 6 months for our amiodarone oxycodone drug-drug interaction. So these are, again, all signs that this is an interaction that we should focus on and either decrease the severity or implement some additional filters to make this alert a lot more specific. If you scroll down on this page, it's going to give you alerts fired by providers. So it will give you the actual provider names, if that person is a pharmacist, clinician, a nurse. So this can be really useful if you need some additional information about why that particular interaction is being overridden. So you could go ask that first pharmacist, why have you overridden 100% of these alerts? Is this not an alert that is relevant for our particular patient population? Or is this one that we just need to filter within the Cerner environment? So in summary, the Cerner Lights On network is a valuable tool for just identifying which drug-drug interaction alerts are firing most frequently, and then how are users responding to those alerts. So knowing which alerts are firing and how users are responding to those alerts are really the first step in alert management. And so with that, any questions that we can answer? So it looks like Megan has a question. Does the Cerner Lights On dashboard allow filtering of MCDs override reasons? So we've defined a lot of MCDs filtering alerts that we can focus on. I believe David is going to cover that. There is some special setup that you need to do. So if you are filtering out a particular MCDs alert, there is something you need to do within the Cerner environment to make sure that that's not being passed over to the Cerner Lights On network. So any other questions before we have David go on and show us some of the tools that he's used to fine-tune some of the alerts?
That's great, Andrew. How about we do that? And then if people have questions, they can jump in later. So Dave, you want to go ahead and share your screen and start your presentation? Great, we can see it. Thank you.
All right, sorry, just had to get myself off mute. So at Northern Light, we had over a period of quite a few years also been working on interactions of all sorts. I'll focus on mostly the 2015 and the 2021 timeframe, two different projects that span that time and the strategies that we used. We have 9 hospitals live with CPOE across the state of Maine, about 250 ambulatory practices that are live with a formulary supported form of CPOE and billing. And 78 of those practices are live with barcode med administration. As mentioned before, we were 2008 recipient of the HIMSS Davies Award at our flagship hospital. And most recently, we've rolled out CPA integrated patient accounting. So instead of interfaced version of that, it's more of a full integration. In the 2015 timeframe, we had an uplift project, which had the goal of reducing over alerting and making alerts overall more meaningful. This was obtained through a multi-pronged approach with preference alignment first, where we had physicians, specifically the non-ambulatory physicians, change from major to major contraindicated. So increase the threshold at which alerts would start to fire for those positions. Ambulatory providers at the time were new to our system and were going live with major as the threshold setting. Although much later on in 2020, they were changed to major contraindicated, like the other physicians as well. And all nurses were also given the major contraindicated setting right from that start point, along with the physicians. Pharmacists were changed from, at the time, seeing moderates to major. And then we also focused on a comprehensive review of drug-drug interactions and the severity changes of each specific DDI. And apply different rule filters. These are 4 standard rule filters that Cerner rolls out: pediatrics, neonates for the calcium rocephin DDI, hyperkalemia, and renal impairment. And they're in the package that I am showing there below for reference. As far as the comprehensive review, we did end up reviewing over 100,000 DDI, including all the moderates, majors, major contraindicated at the time. Which was a daunting task. We did so by grouping it into just over 3,000 related groupings that share the same alert text and thus the same mechanism of interaction. So that made it easier for kind of a batch review to occur with specific exceptions as pharmacists felt necessary. We subgrouped that by specialty area so that pharmacists with specific backgrounds could, with familiarity in certain areas, could be better suited for specific types, subsets of that review, where that was possible. Overall, we had 12 pharmacists over 10 weeks. They spent 120 hours overall total. And we did apply a time estimation to help them kind of know and anticipate how long it would take them to do each section if they were picking up a section for review. And all in all, that ended up being an overestimation. I won't get into it completely, but its formula is basically there. It's fairly simplistic. Out of this analysis, we came up with a variety of customizations. I'm just showing the top 30 by alert firings up to and preceding the changes. The alert firings are off to the far right per month. And I think that was regardless of position. So most of those firings are to pharmacists, but it included physicians at the time as well. And you can see the response, the decision in the customization column, where we were suppressing those high top firings in many situations. In other cases, they were moderate alerts, and we were moving away from that category, so we would just simply not receive them anymore. And then in some cases, we continued decided that it was still relevant to see some of those interactions, so we did not make a change. In terms of the potassium and spironolactone DDI, we upgraded that per Cerner recommendation to contraindicated, so that all physicians could also see it, and applied a rule filter, so it would only fire in context of a high potassium or a missing potassium in the last 7 days, I believe it is. So that's sort of the summary of what came out of that review. This at Go Live, this sort of tracks what happened in terms of the alerts, along with a trend line of total orders. At the top, you see that top line is the number of orders at the time, always and only ever trending upwards. And well, except for perhaps COVID in some cases. But that is tracked along with the axis at the right here. So the total number of orders is on the right, whereas the other lines are all graphed on the left axis with the number of alerts. So there's just 2 different axes going on here. You have the pharmacist receiving the greatest number of alerts, followed by physicians, and then nursing. For the physicians, I've detailed out 17.1 as sort of a baseline per 100 orders, which is not matching the axis, but is a per 100 order normalized kind of a number, which we ended up using that more so recently in our trending. And that underwent a 89% reduction with this project, down to 1.8 per 100 orders. So quite a significant reduction. Here you see the more recent initiative involving multiple different alert types, as it was a pretty expansive project. But in purple, you see the drug-drug interaction line. And that started out with a baseline of 2.23 per 100 order actions. And this is just physicians and extenders, so mid-level providers. And you see that underwent a 72% reduction to now what it is, a 0.61 per 100 orders. So really did significantly decrease it with the combination of these 2 efforts over time. What you see here, the reduction was largely responsible from ambulatory providers being moved up to contraindicated. We also took an MCDs package at the time that allowed our combination meds to more consistently succeed at filtering. And we also applied the discontinue on scratch pad filter, which I'll go into. And this is despite us having upgraded at the time some major DDI to major contraindicated, knowing that ambulatory providers would no longer see them, so that a subset of those were reviewed to determine if they should be upgraded. I'll go into this concept of a unique identifier because it is important if you're going to be cross-referencing data. We do a lot of this in our system where we cross-reference drug-drug interaction content from Multum, our local customization history, our alert firings, combination meds is another factor that comes into this as well. And what we found that we needed to do is come up with a sequence-independent identifier. And the way I came up with something locally that worked is the sum of the unique identifiers of each drug, and that forms the first part of this unique ID. And then the product forms the second part, and then I put dots after that, just so it holds and doesn't drop zeros if it treats it as a number, because I did end up using a decimal dot. And so that ends up working. I incorporate that into our queries, and it helps us cross-reference everything and accurately report upon data. Now I'll go into the MCDs filters that are in Bedrock. Bedrock is a grouping of tools mainly aimed at supporting the analyst in their support processes through these stepwise workflows and at more so efficient approaches at support tools in general. And one of those tools under quality reporting and in-page setup is this in-page setup subset is this medication clinical decision support MCDs. And it's kind of built under M-pages, interestingly enough, but it really is a series of filters that there's a lot in here. And I'll only go into what I've highlighted here with a blue arrow, discern alerts, and then additional filtering rules, inpatient outpatient filtering, order detail filters, and a discontinue on scratchpad. Here is the discern alerts. And I only really point attention at this because it can be easily confused. These aren't filter rules. They're built so that they're display only clinical value on screen. And you can see there's semicolons in between. You apply the rule name here with a semicolon, and you can stack them up, and they will display on the screen. This is an actual example of how it would show lower left-hand corner, you'll see alert information. And if there is something present on the profile, it would show that. And so that can be very useful information. It's not really contextual. It's just showing it regardless if it's on the profile. Now for the override reasons for additional filtering rules, this is what really affects Lights On network. Lights On relies upon a clear indication of what did fire versus what did filter. And that is dependent upon having a very specific override reason. In our case, we use the term system suppressed, and we try to detail out very specific ones to the reason for the filtering where possible, so we can more easily track what was the cause of each filter. Although the system suppressed, it really applies to our MCDs filter rules. We'll eventually split that out as well. But that's important to fill this filter with all of your system suppressed filtered override reasons so that the Lights On data will be accurate. It's also important to have really detailed reasons for users who view alert history on patients' profiles to know that it actually didn't fire. It's important too. The inpatient outpatient filter is responsible for quite a bit of the filtering in our system at over 5,000 alerts filtered in a week. You see here, it has a system suppressed inpatient outpatient override reason applied to it. It's pretty easy to set it up. And you can actually now exclude the FirstNet application. So FirstNet is used in the emergency department and walk-in care setting. And by excluding that, you're basically preventing it from filtering the alert against a patient's home med profile where the patient has just come in. They haven't been an inpatient for days or anything like that. They just came in to you, so that those home meds, the prescriptions, could also qualify for interactions in that setting. So it's a nice way of preventing it from over filtering in those patients. Then you have the order detail filters. These are largely, we use these for our duplicate alerts because we really need to use them. They do a lot of the filtering for us for dupe alerts. And there are only 10 positions right now and only 3 subsets. And your hands are kind of tied to one override reason and one criteria list per each of the 10. So you don't have a lot of ways you can go with this. And one thing I'm pointing out here is we've used this for the Haldol and ondansetron DDI filter, but it's not doing quite what it could do. It's not a dosage threshold based filter. It just allows you to kind of specify 5 different strengths, regardless of what drug they belong to. And so you have four different strengths that we've populated into this filter. And it's only filtering 19 alerts a week. This is going to be planned to be redesigned into an MCDs rule filter where you can have a lot more flexibility about how it would work. And I'll expect it to have a lot more impact. And then discontinue on scratchpad filtering has been a real welcome filter to providers because it's a very workflow centric process. Prior to this filter, if a provider was discontinuing a med and then ordering another thing that interacted with the med they were actively discontinuing, it would send them an alert, which was is never a very welcome scenario since they've already discontinued that first med that it was interacting against. So this filter does allow for that filter to occur and them not to receive an alert against that med. It is sequence dependent though. They have to obviously discontinue first and then plan replacement orders or subsequent steps second. That may not always work into the provider's workflow, but there's no way the system could understand that they're about to do something, but it can understand that they did just discontinue that interacting order. So calcium rocephin or the neonatal and pediatric filters, these are side by side, just kind of showing a much more granular view, but these are very simple rules. These are standard packaged from Cerner. You see the sync event is the trigger. I have the triggers color coded in green, logic in blue, and action in this orange color. And so you see then the criteria or the logic section shows greater than 28 days. And then if it passes these sections, then it goes on to suppress. So in other words, suppress in all patients that are greater than 28 days old. And then of course, this gets applied to specific DDI as appropriate. And the same thing for the pediatric, it's also an age-based filter, much the same structure. Oh, and I forgot to mention that tool that you go into is called Discern Dev. So the same concept here, but I've taken away the detail and really just given high-level criteria. High and missing potassium is basically what this rule is meant to do. It's the same sync event trigger. The rule name is written into that. Then the logic section in blue here, you have if a numeric potassium result exists over the last 7 days and it's greater than the threshold, or greater than or equal to 5, then it would actually proceed to alert, and it would show the user that that potassium level is high. If that potassium result is less than 5, then it would go ahead and filter the alert. If it's not a numeric result, so in other words, less than or equal to 0 is coming back as an in error or free text result should qualify for this, it would basically say to the user a recent level could not be determined, review chart. And then the otherwise in this case is basically saying that no alert has been found in the last 7 days. So sorry, no potassium level has been found in the last 7 days. So the only one that would filter would be the suppressed line. Everything else would show, but the language would show differently within the alert to the user. And this does a good deal of filtering for us, almost 500 alerts in a week. This is an example of where it did fire because of the high potassium, and it shows that high potassium right here in the blue box. So that's very centric to this particular DDI potassium against spironolactone. Here's a MCDs renal rule. So for renal insufficiency, sync event again, rule name, trigger logic action. And so you have the creatinine result greater than 1.5. In most cases, there would also be a creatinine clearance calculated. We have a separate rule that does that if there's a height and a weight on the chart. So this would be a rare kind of a pathway for the rule to follow, because it would usually follow these others. Renal insufficiency based on creatinine, it would show the result, but it would only say creatinine and it wouldn't break it down into mild, moderate, or advanced. Whereas this, based upon creatinine clearance, would break the language down to mild, moderate, and advanced based upon the creatinine clearance level. And if there's creatinine clearance is not found, then it indicates that a recent level could not be determined, review chart. And then otherwise, in this case, it's past all those steps, then it would suppress. So if it's none of the above, then the filter would engage. And here's an example of where there's moderate renal insufficiency based on a CRCL Cockcroft-Gault of 24. And so that ends up showing on the main page based upon the ketorolac versus tenofovir DDI. Here you have what is doing the heavy lifting for us right now. You have potassium, lisinopril, you have all of the potassium, high potassium ones in green, showing that they're doing the bulk of the work. You also have some ped DDI firing only in pediatric patients, and then you have the calcium recepin only firing in neonates for specific DDI here. And then you have the alerts that are filtered overall on the left, but specific to the physicians and the mid-level providers, because some of these are not set for them to even really see these alerts at this point. And so once you build these filters, you do have to apply them to specific DDI. As I mentioned, you do that in the Multum Custom Interactions Bedrock tool, as well as that's where you'd also focus on any changes to severity that would need to occur. And the decision to change severity could change based upon you knowing that there's going to be a contextual filter where it's only going to fire when it's appropriate. So you might upgrade the severity of a DDI simply knowing that that filter is actually going to be doing the brunt of the work. So here's how you'd set the actual rule filter under additional filtering in this tool. You'd indicate spironolactone, then you get a list, you'd find the spironolactone potassium DDI and any of the other relevant DDIs, and you put the expert trigger name as the rule name right here. And that would allow that filter to engage if that DDI were evaluated. Then you have to consider the severity. So it's packaged as major. So it means providers wouldn't naturally see this. So it'd have to be upgraded to major contraindicated, which we see on the right. We have customized spironolactone and potassium to contraindicated. There's a customized button at the bottom. And then you can indicate in the headers that it's contraindicated, because that's how contraindicated level severity is dealt with by the header. So there's a severity level, and then the highest level is a contraindicated header. Once that's applied, then it would fire to providers. This is a breakdown of just the MCDs filters for each of the major position groupings. You have physicians, extenders, so mid-levels, providers, nurses, medical assistants, other, and then pharmacists in their own graph because the numbers are higher. I wanted to show the detail here of what's doing the valuable filtering. Inpatient, outpatient by far does most of the filtering. So home meds against inpatient orders, for instance, except for the ED, of course, that's the exclusion. And then you have high potassium doing a lot of the filtering, followed by DC on scratch pad very closely, or exceeding in the extenders case. And then you have pediatric DDI doing quite a bit of filtering. And then calcium Rocephin, there's very unique case scenarios there, only firing in neonates, otherwise filtering. And this is that same chart broken down basically numerically, but also what this includes is the alert override number and the user response. So all of this stuff in gray had filtered. Physicians, for example, would have seen 1,021 alerts in that week, but 42% of that was filtered. So they only really received these two bottom numbers worth of alerts. And that equates to a 79% override rate, which has dropped quite a bit from where we first started years ago on this implementation. Physician extenders have an even better override rate and similar filter rate. Pharmacists receive a lot more alerts and of course get a lot more filtering going on, and you would expect a higher override rate due to their process flow of verification rather than order placement. They're getting that order secondarily and making a decision as to whether or not they interrupt provider versus making a decision to change their own workflow. And then you can see the remainder of those. And that's the last slide here. At this point, I'm ready for questions.
Thanks, Dave. I appreciate that. There are a couple of questions that have come up. So one was about the discern alert expert sync trigger. Where do you find those rules? And so you might need to back up a few slides to where we're looking at that.
Yeah, so for instance, here, when you're building the rule or you're downloading the rule, there's a package I mentioned. You'd want to take that package into your domain and it should generate, say in your build environment, the name of the rule and the basic architecture. You'd probably have to flush out the criteria, like this threshold in days might not be in there. But it's the name of that rule, which is actually going to be the expert trigger name. So in this case, MCSCAROC. And that can be changed. And as you change it, you have to change that for each of the DDI that you want it to engage for. And you have to separately decide, well, how many calcium forms do I have that I'm concerned about? Because there could be calcium gluconate and so on. And so you have to decide, and there's only one ceftriaxone. So in this case, you're just trying to come up with all of the different drug-drug interactions with ceftriaxone and some calcium containing entity. And then to decide, is that clinically relevant? It would be an interaction, of course, so it would fire. And you could apply the filter so it would only fire if they are neonate. I hope that answers the question.
Yeah, so the individual asked that question. Let us know if that didn't answer it. We'll come back to it. I think so. So there's another comment about changing the severity of alerts and understanding that once it's changed, the content won't be updated in the Multum update. Do you have any comments on that, Dave? Experience with that? If you change those alert severities, how do new updates from Multum affect what you've done in the past?
Right. What we sometimes see is if we upgrade an alert, we tend to see that over time, the Multum tends to upgrade more than they downgrade. And so for all of the ones we've chosen to upgrade ourselves, a few years goes by and Multum probably agrees with those. That's an example of that. So we end up with a lot of, I would call them redundant customizations. You you can run through an analysis, and we have to free up some data before, where we basically now align with Multum. And so we just basically take down the customization. The history would be there still on the table, but once you remove the customization, it would re-engage the standard content. But it does take analysis to do that, to determine where that's a possibility. And then you have to determine, is there a relevant change? So sometimes they change their text. That's another thing that's a good point, is that Multum, last I knew, kind of forces you to customize the text at the same time. So even though we're not ever customizing our text, and there was never a single instance where we wanted to do that locally, we're forced to make, tens of thousands of text customizations because they come along for the ride, so to speak. I really would like to go back, and that would take an initiative to do that, to compare the text now to what is the custom text. And then we would have to re-engage, basically re-customize that alert anew to get the new text to come in. That's a good point.
Yeah, a lot of work involved in that. And that kind of relates to the next question, in terms of effort, how much of FTE is dedicated to, and I'll put it in the context of drug interaction filtering / maintenance. Can you give an estimate of how much you've been having you or your group spend on some of these activities as it relates to DDIs?
It does vary greatly based upon whether or not there is a project that's kind of kicked it off. That's been largely the driving force, because as much as we'd like to dedicate my time only solely to that, I end up getting pulled into all kinds of other projects and initiatives. So I end up getting back to DDI just after this CPA initiative that's taken upwards to a year for me. And in the background, doing dose range checker with the help of another pharmacist, another couple of pharmacists, one of them being an IS pharmacist. I will be refocusing soon on drug-drug interaction, and then it'll be transitioning more into a maintenance role. So I'll expect this other team that starts getting formed for that to help define how much of that how much time it's going to involve. It could easily fill a full FTE. There's no question about it. A pharmacist could be full-time on this, if not two, if you wanted it to be to that degree. Just historically, we haven't been able to devote that much time.
Yeah, thanks, Dave. I appreciate that. There were a couple of questions about the lights on network. So I just want to make sure that we hit that as well. I've got a couple different feeds of information. One comes from chat, one comes from the Q&A. So I think this one's questions to you, Andrew. How did you pull the specific data to make changes? Was all the data already in lights on? Maybe that's to you, Dave. So when you started making changes, was it in the lights on, or did you actually have to create queries to dissect that?
Well, in my case, I did most of our work based upon querying, just because I've gotten in the habit of doing that, and I feel more confident being able to narrow things down to exactly the patient scenarios if I need to, and then summarize it as well. But there is value to, and we have been tracking lights on to some degree. And it does show you what your top firings are. You can absolutely take that approach. We've kind of taken a variety of approaches. Some of them are a top-down firing approach over the years for small subsets for sure. But I kind of highlighted where we also did some comprehensive reviews. I'm not sure if Andrew could add maybe more to that and how he approaches that.
No, I think the Cerner lights on network is kind of a great way to start, so you can at least identify what are the most frequent drug interactions that are firing. So you always want to make sure you're spending time on alerts that are going to have a lot of impact. So I always prefer to either do it with queries or the lights on network, kind of depending on whatever you're most comfortable with. But they should both get you the same amount of data. It's going to allow you to identify the alerts that you can focus your time on.
Yeah, thanks for the response, gentlemen. There's a couple other questions. One is about the MCDs underscore renal underscore 2 rule. Is that available across the Cerner platform? Do you know?
It should be, yeah. There's probably a greater degree of customization with that rule, because for each of these cases, you have to determine what your event codes are going to be for renal function, and then what your thresholds are going to be. So there's a little bit more decision making here, and what you would send as an alert to the user. But from what I understand, that one's available in that package as well for download. And that package was package number, let me see, so go to slide 3. Sorry for jumping around so much, but that should be this one. That package here, 94756, was the most recent I could find at the time that should include those rules.
Great, thanks, Dave. So one of the questions we have, is this for inpatient only, or does this affect the ambulatory environment as well when you make these changes, Dave?
Yeah, it does impact the ambulatory environment as well as prescription writing. So they get these alerts, and there's nothing, I think, for any of the ones I'm mentioning that stops the filter for those cases. The only thing to bear in mind is that in the ambulatory environment, potassium within the last 7 days becomes more of a rare event. And so the dynamic does change for those time-centric, lab-centric events. Potassium in the last 7 days, actually, I think it's a scenario, actually.
Yeah, that makes a lot of sense. And then there is a question about the venue of care filtering. So I think you said this, but I want to just double check. You know, there's sometimes, I guess you want to filter based upon where the patient is currently. And I think you said that you did some filtering or did not filter, I guess, in the emergency room environment. Are there other venues where you've excluded filtering from occurring? Or
not for these. You could technically, for these rule filters, I believe, incorporate a venue and care encounter type of a filtering, if it made sense to do that, or an exclusion, so it wouldn't over filter in some cases. We didn't apply anything like that. And then this one filter that includes the first net, which is, yeah, right here. It's part of their hard-coded options. It was added at one point, and it was a good thing they did add it, because initially we turned it on and we were over filtering. We had some ED providers concerned about the fact that in that workflow setting, their home med profile is their profile, so to speak. There is no inpatient profile, so they would want checking against it, and so they were, you know, that really addressed directly a concern that they had.
Yeah, and I may have misunderstood the question. I guess certain medications and the exclusion, I guess, and Dave, you built a process so that you can drill down pretty specifically on which medications are included or not included in your filtering rules.
Right. So if it's an MCDs rule filter, you're applying that to specific drug-drug interactions. So it's up to you if you apply that to a particular potassium phosphate interaction, or is it a potassium chloride interaction? It's up to you to kind of determine where you would apply that. In each combination drug, it's a separately customizable interaction, which I don't necessarily agree with that functionality, because it upgrades. Instead of 100,000, we're probably talking about 600,000 DDI now to kind of try to manage once you deal with combo drugs and the need to customize them separately. But that's a separate issue.
Yeah, totally. These have been great questions. I think we're getting to the end of it, into the questions, but I'd like to just, Dave, if I could grab the screen share back from you.
Sure.
So thank you very much. Very informative. Okay, let me just make sure that I can share my screen again. I'm trying to get this to bring up. See it coming up yet. So, one of the challenges with some of this technology when we swap across different systems here makes it a little harder for me to see some of the options. So for some reason it's, okay, there we go. Want to just alert those of you on the call to something else we've been working on. We'd love some input back from everyone if you have an opportunity to do this. We have a new tool for kind of talking about how to display risks for drug-drug interactions. So we have a beta version of a particular drug interaction. This is a warfarin NSAID interaction where we're trying to incorporate both patient factors and various medications that might increase or decrease the risk. We have this tool available at our website under our apps component, or the URL you see at the bottom of the screen. And basically, if you go to this section of our website, you can launch this app and interact with it. It's dynamic. If you're on the website for a few minutes, there'll be an opportunity to participate in a survey about the tool. We're collecting information. We'd like to hear from you about how the tool works and what you'd like to see, or what questions you might have or issues you might have with the tool. So feel free to explore our website as it relates to different ways of displaying risk. This particular tool was developed in the context of a patient visiting a provider, and so it's not pharmacy centric. It's more clinician environment centric. So it's at the time of order prescribing versus order verification. But anyway, we'd love to have your feedback on this tool and participate in our survey. There is a small incentive for participating. We appreciate those that agree to participate in that process as well. With that, I think we're going to wrap it up for today. So thank you very much for attending our program. We're continuing to roll out new tools and new issues. So this has been extremely informative, I think, in terms of the Cerner environment. Love to hear your comments. Feel free to reach back out to me directly at dan.malone@utah.edu or via our website at info@ddicds.org. With that, we'll go ahead and wrap it up. Thank you for attending and have a great day.